Okay, great. Well, greetings from Houston, Texas, where given the current weather epidemic and power shortages, we know the importance of learning from our failures and planning for the future. I will say that. I'm incredibly grateful to be here with you today. And I've learned so much in my career from Mark over the years. I'm just honored to follow him up. And given a lot of what we heard today, I'm going to talk about lessons learned from the OSHA bloodborne pathogen standard and also helping us to think about how we build our plans for the future. So hold on here. I'm going to start with some lessons learned from some data that we did on enforceability of the OSHA bloodborne pathogen standard, looking over 25 years at the time of the history of the standard and enforcement of the standard. I did this with several of my colleagues at OSHA and presented this at the American Industrial Hygiene Association conference with Dr. Mike Pinnell, who was formerly of OSHA and now at NASA. Can you believe we landed on Mars? So here are some similarities for the standard. As Mark indicated too, the elements of the OSHA bloodborne pathogen standard really do follow a lot of the aerosol transmissible disease standard from California, Oregon, Washington, Virginia, in assessing the real importance of building the exposure control plan. Again, really, this is a living and breathing document that needs to dictate how a workplace is addressing hazards. Now, again, these are bloodborne hazards. These are not aerosol transmissible diseases. But again, the priorities are the same for assessing importance of engineering controls. In the case of bloodborne pathogens, these are safer medical devices that eliminate sharps, personal protective equipment, work practice controls, and the like. So again, just a hierarchy of how the standard is set up. So what we did for this study was, again, looking at 25 years of enforcement data, which really sets the stage for wherever OSHA is going to go next for either an emergency temporary standard or an infectious disease standard. So we looked at over 30,000 inspections over 25 years. So this resulted in 77+ thousand citations. So when an OSHA compliance officer goes into a facility and they do an inspection, that's one inspection, but one inspection can result in multiple citations. So that's why those numbers are how they are. And then we looked at the citation itself. So what was the citation matter of which paragraph? So did the employer not have an exposure control plan in place? Was it not updated annually? Did they not have engineering controls in place to protect workers? Were they not wearing appropriate personal protective equipment? So these are all potential citations that could be issued. We did a bunch of coding. This isn't really all that interesting to you, but what I did want to show you was the results. So we broke up the numbers of inspections by 5-year time period. And you can see here at the very beginning of the standard, as Mark was talking about, the beginning of isolation precautions, the beginning of contact precautions, the beginning of universal precautions. When the standard came out, it was issued in 1991 and was enforceable in 1992. You can see the largest percentage of citations were in that very first time period. The second largest was after the Needle Stick Safety and Prevention Act was issued. So that was issued in November of 2000 and was enforceable by OSHA in 2001. And this was when I was at the agency as the National Bloodborne Pathogens Coordinator. So citations blip over time based on events. And you can see that in the very beginning of the standard, high number of inspections, and then again after the Needle Stick Safety and Prevention Act. But then you can also see over time that citations have dwindled quite a bit. In the 2011 to 2014 time range, there was only 13% represented in the total 100% within that time period. The largest percentage of citations were simply because employers did not have an exposure control plan. I can tell you, having done many inspections, that the first thing a compliance officer asks for when they go into a facility can I have your plan? And it needs to be accessible to all employees on all shifts. They need to know where it is. It needs to be updated annually. And this represents, hold on, I need to move myself here. This represents, as you can see, almost one citation per inspection. So this is a really critical part of any workplace plan, is actually having a plan. I've done inspections where you walk into a facility. This is now the bloodborne pathogen standard is a horizontal standard, which means it applies to multiple industries. Any industry that has an employee with occupational exposure to blood. So the first thing you ask for is the plan. The second thing you typically ask for is the OSHA record keeping log, or in this case, the Sharps injury log. I've seen employers that have had plans that they've purchased that are still wrapped in cellophane up on the shelf, which is clearly not a workable plan. So when we look at the types of citations, now the bars represent different time periods. And you can see here that the time periods change based on, so frontline worker input was a faction of the Needle Stick Safety and Prevention Act. So it went into effect in 2001, which is why you can see the severe time difference here. But so these were failures of including frontline workers in the evaluation of engineering controls, and then failure to document that in the exposure control plan. But you can see here, hold on, I need to move myself again. You can see here from the citation data that, again, the largest percentage of facilities were not complying with a very simple element, which was having an exposure control plan that was reviewed annually, updated annually based on the changing risks in that facility. And then still here, the availability of engineering controls or engineering controls were not used. And in this case, again, engineering controls are those that eliminate hazards to blood or other body or other potentially infectious materials, meaning devices with Sharps injury prevention features, needleless devices, and the like. So you can see here all of the lessons that could be learned for the future of an infectious disease standard or an emergency temporary standard. So these were the conclusions that we came up with several years ago based on that data. OSHA enforcement really does drive employers to compliance, and we didn't know at the time what was next, but we thought that analyzing this enforcement data was important for whatever infectious disease hazards were ahead. Of course, we were thinking about bloodborne hazards like Zika and Ebola, but clearly relevant to today and coronavirus or COVID-19. And then really important was how we would assess compliance based on the risk in healthcare at the time, but really in any workplace. Again, the bloodborne pathogen standard applies to all workplaces based on increasing prevalence of bloodborne pathogens. So hepatitis C, co-infection with hepatitis C and HIV, really prevalent in communities that are vulnerable or have reduced access to healthcare. Now, at the time, we thought, well, what does this mean? Does OSHA compliance really mean that workplaces are protected? Does a standard really mean increased public health elements? Do the numbers of citations really indicate whether an employer is complying or not complying? Do more inspections mean that they're complying or not complying? So these were just questions that we were asking back then. And should facilities be compelled to report their injuries and exposures? So their employers are required to keep exposure logs. They're required to keep a Sharps injury log, but they're not required to report that anywhere. So should we bring back mandatory reporting of injuries and illnesses to either OSHA or the Bureau of Labor Statistics or some means outside of the employer's doors? So how does this mean that we should make data-informed decisions? When we heard earlier, I think, about keeping track of when exposures are happening for COVID. And we do have national surveillance systems in place for bloodborne pathogens. At the International Safety Center, we've been collecting EpiNet data since the early 1990s, which has informed a lot of decisions we've made on bloodborne pathogens. But what I'm going to show you may shock you if you haven't seen EpiNet data before on the lessons that we know now based on really low compliance with personal protective equipment. So the International Safety Center is a nonprofit. We've been collecting surveillance data for sharps injuries, as I indicated, for many decades. It started with one of my mentors, NYNJERC at the University of Virginia. So I'm just going to share a little bit of that. Now, again, COVID is not bloodborne, and I'm not telling, I'm not saying that needle sticks are affecting the transmission of COVID. But as we increase mass vaccination programs around the world, thinking about using more and more syringes, thinking about workplaces potentially offering vaccine programs and vaccination programs, needle sticks are a very real reality as we're thinking about protecting healthcare workers that are doing vaccination programs. And we already do know from our EpiNet data that the greatest majority of injuries that are not in the operating room, so sutures are the largest number of needle sticks or sharps injuries that are occurring in healthcare facilities, but again, these are in the operating room. The second largest is from disposable syringes, and we know this already. So this is our 2019 data. We're actually analyzing 2020 data right now. But I would say that if we're looking at mass vaccination programs, again, these numbers are only going to increase with the more devices we use. And we do know from our EpiNet data that the largest majority of injuries are from insulin, and the 24-25 gauge syringes are those that are used for intramuscular injections, meaning typically vaccinations. And even though there is a requirement within the OSHA bloodborne pathogen standard to use engineering controls to prevent sharps injuries, that 52% only 52% said that they were using an engineering control, but of those, more than 70% said they did not activate the safety feature. So they were using a safety device, but did not activate the safety feature, which means that having an engineering control isn't enough. Workers really need to know how to use them and how to use them safely. So this is what we collect also as mucocutaneous exposures. So these are blood or body fluid exposures to eyes, nose, or mouth, and a lot of lessons learned from bloodborne pathogens or from our surveillance data set that could inform future COVID or coronavirus or infectious disease, aerosol transmissible diseases, whatever a future standard is going to hold. So of all of our facilities that report into EpiNet, we already know that almost half of all exposures are to unprotected eyes. These are extremely high risk. The eyes have the vitreous and aqueous humor. They have a lot of blood vessels. So these are extremely high risk exposures, more than half. And the reason why this doesn't really add up to 100% is because when there is an exposure to the face, there could be multiple exposures to the eyes, nose, and or mouth. So again, these are extremely high risk exposures. And then when an employee is asked, okay, you had an exposure, where did it happen? What personal protective equipment were you wearing during the time? So remember, COVID, coronavirus can be spread through the mucous membranes. We already know this from aerosol science. We already know this from infectious disease science. So again, these are employees that show up to occupational health, they report their exposure, and they fill out all this information on the EpiNet database. So when you had an exposure, what personal protective equipment were you wearing at the time? And so I just showed you that almost half of all exposures are to the eyes, but then only 3.6% indicated that they were wearing any kind of eye protection during those exposures. And there's so much focus right now on personal protective equipment for coronavirus, but we already know from our 2019 data, and I'll tell you that all the former years, decades before, indicate that very few people are actually wearing any type of face protection. And look at the 0% in 2019 said that they were wearing a respirator during the time of their exposures. So our 2020 data is going to be very, very different, but we knew in 2019 and all the years before that this was an issue. So this is a really busy graph, but this is just to show, again, the blue bar here are numbers of eye exposures, and then the orange bar is number of people wearing eye protection of any kind. This is a huge gap. It's been a huge gap for a very long time, and this is data that's been widely available for decades, where we could have learned from our mistakes or our failures. So what do we do for the future? For the future, there's so much availability of national data from what we've learned from bloodborne pathogens that could be taken up into whatever is to come next. And as Mark did say, a lot of the aerosol transmissible disease standard from California is modeled on the bloodborne pathogen standard. So much to learn, and really the importance of simply building an exposure control plan that is a real evergreen, living and breathing document that changes based on what we know, that changes based on what the risks are, that changes based on what we know from our own data and failures in use of engineering controls and personal protective equipment from data that is already out there. CDC does not collect occupational or hasn't collected occupational exposures to bloodborne pathogens since the NASH database, and I want to say that stopped somewhere in the mid-1990s. So with EpiNet, we are the only organization that captures mucocutaneous exposures from an occupational point of view. Just as a reminder, we are on the 20th anniversary of the Needle Stick Safety and Prevention Act, and it's a historic year. I'm just so proud to have been a part of the original piece of it, and so many of you out there in the occupational health and safety world that served as my mentors during the time that this was passed in 2000. In that document, in that consensus document, we have a ton of suggestions for preventing occupational exposure to bloodborne pathogens. But again, this can be used for building an infectious disease plan as well for COVID. Now, I presented several years ago to the Critical Care Nurses Association and asked them, just thinking about PPE, where have the gaps been in your facility? And this was several years ago. Many of them said, there's an infection control cart that we use for patients that are on isolation, but I have no idea where it is. I don't even know where the eye protection is. So it's really no wonder that we've had a bunch of failures. And as Mark said, and I completely agree that healthcare, and we're not just talking about healthcare for COVID, but within the healthcare experiences that we know, there really has to be more focus on worker safety as an element of overall healthcare safety, and not just focuses on patient safety. Improving accessibility. So as I mentioned, and this was several years ago, many nurses didn't even know where the infection control cart was. So should we build a system in healthcare that's more like manufacturing? So you cannot step past this yellow line without putting on your hearing protection or without putting on your hard hat. There are many, many different cues to action that we could increase in the availability of personal protective equipment within the healthcare community. Again, PPE very low at the bottom of the hierarchy, but just as an example of what we know from the bloodborne pathogen standard, there are all kinds of innovations in textiles now too. Again, I know PPE is very low on the hierarchy of controls, and there should be more focus on engineering controls. So what does that mean for what textiles look like? Because by the way, we know contact for COVID is lower than aerosol, of course, but for any other microorganisms, as we're thinking more broadly about an infectious disease standard, They are transmitted via textiles. Textiles are have perfect little nooks and crannies for bugs to hide. So thinking about engineering textiles within an infection control, a broader infection control paradigm might be something to consider. There are a ton of great sample plans, and I'm happy to share all these slides for you. The NYEHS, as Mitch said, I serve as a science advisor to NYEHS. We have put together within the worker training program some outstanding tools. Shout out to everybody here from NYEHS listening in. The Center for Construction Training and Research has done also some really fantastic model exposure control plans. I highly recommend, if you haven't seen them, to use them. You don't need to buy my book, but there are also some great tools in the book on building infectious disease plans using a hazard analysis matrix for where risks are and how you would prioritize assessing those risks. I would recommend a more robust surveillance system, more than just what the OSHA 300 or 301 logs require, or even what the Sharps injury log requires, that allows your exposure data or your incident data to really tell the story about where to focus and how to build targeted campaigns. That would include doing a rounding checklist. There were questions earlier about increasing the visibility of occupational health and safety professionals in the realm of occupational infection prevention and control. I've been so frustrated in my entire career about infection prevention and control, really focusing not so much on worker safety and thinking about rounding from a healthcare point of view, not just rounding for patient safety or rounding for quality, but really rounding for occupational health and safety. Again, other tools for just building a robust hazard assessment. I've already showed you this. And then also, what this looks like. Robin was talking about social distancing, physical distancing, partitions, building these little paradigms, or whether they are posters or communication tools for workers. Many people learn in many, many different ways. So just some other examples. And then I have a ton of resources for you. This came out from our friends at OSHA recently. It's very comprehensive. There are more than 100 different resources within this plan that OSHA has together. We just launched a series of safety protocols and program designs, model vaccination programs for those that are, if they are choosing to do vaccination programs in the workplace. Again, really important to protect those vaccinators from Sharps injuries with the greater use of injection devices. These are the tools from the Safety Center, again, not just for bloodborne, but also for infectious diseases. We have a ton of data for facilities that want to compare how they're doing or learn from what data we've collected. We have also some really terrific tools for evaluating medical devices, evaluating personal protective equipment, face shields, respirators, and the like. This is really old. The hospital e-tool is really old, and I'm hoping OSHA does update it. But again, just another example of a really terrific interactive tool that's available for people as they build their programs. And that's it for me. A ton of references. Again, I'm happy to share my slides, and I'm just so honored to be here with you today. I grew up on Long Island, so I feel like I'm back home again. So thanks again, Mitch, for inviting me.
Thank you, Amber. Happy to have you here and to provide your expertise to our audience here. So a couple of questions for you. Where do medical students fit in under the OSHA standards and regulations? Their continuous risk for exposures to bloodborne pathogens and COVID while carrying out their clinical responsibilities in the hospitals. However, they're not categorized as employees of the hospital.
So it's a really great question. And in the EpiNet database, and I'm happy to share that too. We actually do capture injuries for medical students. Now, if a medical student is not paid by that facility, they're technically not an employee, so it wouldn't show up on, let's say, Houston Hospital exposure law or their Sharps injury log or their OSHA 300 or 301. But if they are paid by the university in any way, and actually the university needs to keep track of their student injuries, so that employment element and whether they're paid or not gets to be a little difficult with how things are captured on the OSHA 300 or 301 log. But again, if they do show up at Employee Health, we do capture them on EpiNet, and I'd be happy to share those too. Mark, you have a lot of experiences too with OSHA recordability for bloodborne, or if you want to add anything to that too.
No,
or
I think
anybody
you covered
else.
it. Yeah.
Thanks. Another question is, many healthcare facilities have faced shortages of syringes and needles and have brought in new and non-safety devices. Do you think looking at the bloodborne pathogen exposure incident data during COVID will be helpful?
I do. I really do. I think so. I've been approached by many colleagues at NIOSH and other experts in the field of bloodborne pathogens and Sharps injury. Unfortunately, the data that we collect for EpiNet is a year behind. So we capture it every year from our network hospitals, and then it takes us a few months to analyze it. I wish there was a way where we could capture more real time, or if not real time, at least in a shorter period of time, data so that we could learn more quickly, because capturing data a year out or a year and a half out isn't fast enough, in my opinion, and especially as mass vaccination programs are launching around the world, it would be fantastic if there was a way to identify more quickly where the injuries are happening, how they're happening, if facilities do not have Sharps injury prevention devices. I have heard anecdotally from everybody that I've asked that the kits that are being sent out for the vaccine programs are coming with devices with Sharps injury prevention, which is good news. But if anybody hears any differently, or if anybody has any ideas on how to better protect healthcare workers from Sharps injuries, I'd love to hear it.
Great, thank you so much.